Well, good afternoon, everyone, and maybe good morning to some of you. We're very excited to open up the 2020 STD Prevention Conference. Before we get started, I would like to take a moment to acknowledge that you are experiencing right now this year's STD Prevention Conference that is unlike any other. COVID-19 has upended so many aspects of our lives, and this conference is no exception with our move to a virtual format. This year's conference theme is 2020 Vision, Disrupting Epidemics and Dismantling Disparities. These words feel more urgent and more relevant than ever before. The pandemic has exacerbated numerous disparities in health and in healthcare. Today, STD prevention colleagues from across the country, we actually have over 1,000 from 61 states and countries, have gathered to chart the way forward to discuss how we adapt to rapidly changing public health and healthcare landscape and find new and better ways of working through the pandemic and beyond. I want to thank all of you for participating and for helping us take stock of where we are, what this moment means for STD prevention and public health, and how best to move forward. So before we get started with our plenary speaker, first I would actually like to thank my co-chair who will be speaking shortly. Shaquetta Johnson is a member of the NCSD Board of Directors, and she's Deputy Director of the STD HIV program in the Louisiana Office of Public Health. I would also like to thank the Scientific Committee. For those of you who do not remember, because it seems like it was so long ago, pre-COVID, is that this conference actually started out as a face-to-face conference, and our scientific agenda was built on assuming we were having a face-to-face meeting. So we invited a lot of people, and we felt for the purposes of equity, it would be unfair to start inviting people once we know that we were going virtual. So that has added a huge dimension of, we've got over 180 speakers, half have been videotaped, and obviously I think most virtual conferences will not have the content or the amount of content that we're going to be presenting to you. So again, thanks to the Scientific Committee chairs and co-chairs, Seth Guillerel and Jamie Litliker. Our track committees included the Assessment Committee that was co-chaired by Preeti Pathela and Hillard Weinstock. Our Assurance Committee was co-chaired by Laura Bachman and Susan Phillip. Our Program Definition and Prevention Services Committee was co-chaired by Matthew Hodgman and Julie Dombrowski. Our Clinical and Laboratory Committee was co-chaired by Ellen Kurse and Phil Chan. Our Evaluation Committee was co-chaired by Patty Dittis and Patricia Kissinger. Our Policy Committee was co-chaired by Gail Bernstein and Bill Pearson. And our Clinical Case Series by Laura Quilter and Brad Stoner. So a big, I don't know if we can see anybody applauding, but a big round of applause for our Scientific Committee. But the most important people who have been working tirelessly for months, full time on getting this conference going virtually is Shamika Jennings, who is from NCSD with the support of David Harvey, the Executive Director of NCSD. And then our CDC coordinators are Patricia Jackson and Allie Michelli. And so we also want to really thank them. It's too bad that we can't see everybody, but big kudos to what they've done to get us to, at least we're logged on and we're starting our conference. So I'd like to turn it over now to Shaquetta to give some remarks about NCSD and anything else you'd like to talk to us about.
Thank you, Gail. Good afternoon, everyone. I am Shaquetta Johnson, Deputy Director of Operations for the Louisiana STD HIV Hepatitis Program. And on behalf of the Scientific Committee and the National Coalition of STD Directors, I am honored to welcome you to the 2020 STD Prevention Conference. As we all know, we are living in challenging times, and the STD field has been on the front lines responding to COVID-19. Rising STD rates before COVID will be further exacerbated by the pandemic, and our field is preparing for that eventuality. In addition to the latest scientific advances, you'll also hear about our field and how its vast knowledge and years of disease prevention expertise are helping to fight this epidemic. 2020 has been one of the most dynamic years in our field in recent years. There is no doubt that innovations in clinical care and prevention are happening each and every day, driven in part by COVID-19 response. Advances in telehealth, at-home STI, home collection STI testing, and online partner services are just a few of the changes that will live on long past COVID-19. Again, we welcome you to the first ever virtual STD Prevention Conference. The CDC and NCSD teams have worked very hard to bring you this thoughtful, exciting, and interactive meeting. Please be sure to check out the conference posters, which will be released tomorrow, Tuesday, September 15th at 3:30 p.m. Eastern Time. And there will also be a poster contest on Twitter, #SelfieWithScience, so don't miss it. And please, please, please post about your conference experience on social media using #STDCONF20. Now I'll turn it back over to Dr. Boland to introduce our outstanding opening plenary speaker. And again, we welcome you. Dr. Boland.
To announce that this year, David Mailbranch is here to introduce and kick off the conference. Before I get to his most exceptional title, if you don't know David, he's in internal medicine and a sexual health physician, public health official, and educator who lives in Atlanta, Georgia. He appears in the YouTube series Revolutionary Health as part of the Counter Narrative Project, and is also on the #AskTheHIVDoc video series. His writings and research have been published in JAMA, the Annals of Internal Medicine, the American Journal of Public Health, and Lancet. Dr. Mailbranch also penned a memoir entitled Standing on His Shoulders about his relationship with his father. And today he is going to speak about Naked and Afraid, why we need to disrobe and expose flawed systems, institutions, and people if we are serious about disrupting STI epidemics and disparities in sexual health. Thank you so much, David. Thank you.
All right, thank you very much, Gail. I hope everybody can hear me okay. I cut down on my title a little bit, and I want to thank the CDC for inviting me to be the opening plenary speaker for this conference. So I cut it down a little bit to Naked and Afraid, Disrobing and Exposing Flawed Medical Systems to Achieve Sexual Health Equity. Dr. Johnson, Shaquetta Johnson, mentioned 2020 being the most dynamic year ever. I actually have a different phrase for it. I'll call it the worst year ever. And I think I wouldn't get a lot of disagreement from a lot of people, but I'm glad Dr. Johnson has a good spin on things. I just want to give you a little bit of context of what brings me to this point. My father, unfortunately, passed at 87 years old in early January. I had to take an unpaid leave of absence from Morehouse School of Medicine in New York. COVID-19 hit. I was taking care of my mother, working with her, trying to get her moved to California when she needed surgery for her knee. We experienced an acute on chronic racism epidemic and are still experiencing that as I speak. And I unfortunately had to leave my job. I resigned from my job at Morehouse School of Medicine on August 1st, because when I returned to Atlanta, it was obvious to me that I needed some time for healing and getting some other things together. So that's what I did. But I say all that to say, not to get you all in my personal business, but to say I'm not the only one that's been going through a lot. So for those of you who are watching and who are there listening and participating, and most of all, the people who worked on getting this conference together, we are all going through similar things. And so people being sick, people losing jobs, people losing family members. So I just want to commend you guys for all being here and applaud everyone who's in the audience and paying attention today. So Naked and Afraid, where does that title come from? When Matthew Hogben asked me to do this, and I was thinking about things, and obviously we were quarantined in March when he asked me to do this plenary, I thought about one of my favorite TV shows, which is Naked and Afraid. And I'm not going to lie and say something like I was only binging it because we were quarantined. I was actually watching this years before. And for those of you that aren't familiar with this show, Naked and Afraid takes two people who are kind of like minor survivalists. They call themselves self-proclaimed survivalists, puts them in a very inhospitable area of the globe, where there's little access to food, water, there's a lot of predators around, so on and so forth, inclement weather, and they give them nothing. They have to strip down and be naked, and they're afraid and scared, and they have to deal with all the elements for 21 days and work together as a team, and they're meeting each other for the first time. They usually pair it seems like a cisgendered woman and a cisgendered man, and then they follow along. So I thought it was interesting, and when we talk about STIs, as I'll kind of break down here, I thought it was an interesting metaphor that we could use. And when I say naked and afraid, it could reflect the general feeling that we have in this country right now among a lot of us. It could reflect how we navigate sex and intimacy in these days and times. And for those of you that were on one of the previous sessions, Dr. Julia Marcus, who I was absolutely ecstatic to see her because I follow her on Twitter and always love her writings, actually mentioned about having sex and the difficulty that people have, and some of the New York City Department of Health recommendations that were absolutely wonderful in helping us navigate our sexual behavior during a pandemic. Naked and Afraid can also refer to patients going to medical centers for sexual health services. They have to show their genitals, they feel very scared. And then finally, Naked Afraid can also refer to us as clinicians or medical staff members when we're charged with addressing racially and sexually diverse patients. A lot of us feel extremely naked and afraid when talking about topics that are outside our regular jurisdiction. So when you're naked and afraid, that usually makes you vulnerable. What's our typical response to being vulnerable? We avoid, we hide, we run. And for medical professionals and particularly clinicians, we shield ourselves behind our biases and medical terminology. So we talk fast, we move quickly, we use big words that people don't understand, and we let our biases show through, and then we just move on because we feel vulnerable and scared. So I'm going to tell a little story and weave this in throughout the course of this presentation. So I want you to picture this. You have a college student who's Black and gay. He's in summer school, but at a different institution than the one he goes to during the regular semesters. He's HIV negative and on PrEP. He had a negative syphilis screening in the past year, and he has no current symptoms. He reports having sex multiple times, sometimes condomless, with one partner in particular over the past 30 days, who now has told him, "I think I have syphilis." So he goes to student health at the summer school, and he sees a PA for an evaluation. While he's there at the visit, the friend tells him to confirm, "I just got my test back. It actually is syphilis." And so the student tells the PA and lets them know, "I'm here. He's confirmed he's syphilis. I have an exposure." The PA tells him that he can't test him for syphilis because he gives him 3 reasons. He should be tested for all STIs, not just syphilis. He's uncertain about the follow-up since he's a summer student there. He doesn't know whether he's going to follow up at that summer school clinic or not. And then he also gave the excuse that it would take 3 months before something, quote unquote, shows up with the test. So he turned him away from the student health clinic and just referred him to some local, give him a list of resources, local Department of Health or CBO for evaluation. So for context as to why I knew about all this, I was his primary care provider at the primary school. And the student had actually been on PrEP that I had prescribed to him. So while I was away in Seattle at a board review course for the internal medicine boards, he was texting me this information. And for those of you that are concerned about this, I already had texted him about whether it was okay to use this story without, of course, giving his name, but that's part of the picture that's going on. So why be afraid? Why should we be afraid in these days and times? Well, if we look at 2018, the state of STIs in the United States, we see that things have been going up over the past few years. So you'll see on this slide, 1.8 million cases of chlamydia, 19% increase since 2014. Gonorrhea cases have gone up about 63%, syphilis cases 71%, and syphilis cases among newborns, congenital syphilis, has seen a 185% rate increase since 2014. So those are very dramatic. So we're going in the wrong direction. We were going in the wrong direction even before COVID-19 hit. And this graph will show you, this is from the CDC as well, will show you that youth actually represent a substantial proportion of new STIs. You can see across the board from gonorrhea to chlamydia, HPV and genital herpes about 50%, HIV and syphilis not so much, but for gonorrhea, chlamydia, HPV and genital herpes, at least 50%, close to 50% and above that we're seeing that ages between 15 and 24, adolescents and young adults, are comprising these new cases of STIs. And this graph will show you from chlamydia, again, most of this data, if not all of it, is from the CDC. Chlamydia rates of reported cases by sex. And you'll see women have higher rates and have been going up for the past 2 decades, and with men as well. Gonorrhea rates of reported cases, same thing, but we'll flip it. The men have a higher reported rate than women. And that's from 2000 to 2018. And then for herpes simplex virus type 2, this was a study that was done among persons 14 to 49 years by race and Hispanic ethnicity. And they did antibody testing for herpes type 2. And this is just a prevalence cross-sectional analysis from NHANES. And what you see is for non-Hispanic Blacks, there's a racial inequity. You're looking at close to probably 35, almost 40% as compared with other races and ethnicities. And then for primary and secondary syphilis, when we again look by sex and male to female ratios, we see that men are far outpacing women with not only the rates, but as far as the ratio is concerned as well. So you see with all these kind of dynamics, what's happening with STIs in this country, and particularly over time, things have been getting worse. So let's continue with the student story that I'm telling you about. The student calls me for advice after about 5 p.m. and many of the clinics have been closed. I was away, and like I said, I was his prep PCP. I referred him to urgent care. He has insurance and pays a $25 copay. The provider over there gives him doxycycline, 100 milligrams twice a day for 14 days. And he calls me back or texts me back and lets me know this is what he gave him. And I asked him, I said, are you allergic to penicillin? And he said, no, I'm not. Why? And I said, well, penicillin is the primary treatment. That's the first line recommended treatment that we have. It's an injection. You can only get the shot once. And I asked him if the provider had actually mentioned that to him, that there was an option. He said, no, they just gave me the pills. So what he did was he called the clinic 3-way with me on the phone, and he had already gone home. He had just resigned himself that he had to take pills twice a day for 2 weeks when he could have gotten a shot that would be a better treatment. And he got the provider on the phone or called the clinic. And this is what happened. I spoke with the medical assistant while the patient was on the phone. And she tells us that the nurse practitioner who saw him was charting. And I asked them about the penicillin, and she said, well, we don't give shots here. And puts us both on hold to speak with the nurse practitioner, and then returns and says, well, the nurse practitioner will call the penicillin shot into the pharmacy. And typically pharmacies don't inject penicillin shots. They don't do the penicillin shot. That has to be at a clinic by a nurse or someone else who's qualified or who has gotten training in that, unless they have a clinic that's there that they can do it in our stock. And I called the pharmacy and asked them, and they said, no, they don't do shots there as well. So I confirmed it. I notified the medical assistant that we would actually send him someplace else. And we hang up the phone, and by then it was about 9 p.m. on Thursday night. And I kept thinking to myself, you know, the frustration, because the patient was frustrated. I was getting frustrated. And I was thinking, this is not how it works. It's just not how any of this is supposed to work. And so if we go back to some of the data and some of the rates that we're seeing with STIs, we see primary and secondary syphilis, rates of reported cases by county. This is in the United States from 2018. You see the rates, the higher rates are in the darker colors. And you can see, as we see with HIV, COVID-19, poverty, uninsured, we'll see states that endorsed slavery back in the 1800s, as Dr. Mena brought up in his earlier presentation. You see the darkest places are in the Southeast and in the West Coast, and the highest rates of primary and secondary syphilis. When you look at chlamydia, you see the same thing, but you see kind of a darkening of the whole country a little bit more with chlamydia, but again, in the Southeast and in the West. And then finally, for gonorrhea, you'll see the same thing, a similar kind of display there. When we look at this bar graph with primary and secondary syphilis, these are reported cases by sex and sex partners in HIV status from the United States in 2018. What you see in the orange bars are for HIV negative, the red are HIV positive, the slightly lighter color orange or yellow is unknown HIV status. But you see among men who have sex with men, there's high rates and a high number of cases of primary and secondary syphilis, even if they're HIV negative. you see that kind of goes down. Men who have sex with women, a lot lower, and then women lower even. But you see with HIV negative, it doesn't seem to be something, particularly for men who have sex with women and women themselves, that this is something that they see. It's primarily driven by men who have sex with men. And then when you look at primary and secondary syphilis and some of the racial breakdowns and by Hispanic ethnicity, and this is again from 2018, you see the male rate for Black men is disproportionately higher than any other races and ethnicities. And for women, it's higher than everyone else except for American Indians and Alaska Natives. So you can see when you talk about a patient who is sitting at the intersection of being both Black and gay, same gender loving, and also living in the South, it's a hotbed for syphilis, hotbed for a lot of the other STIs. And so as providers and as clinicians and as people that are working in these sessions, we need to actually be a little bit more aggressive with these things. It's a good time now to talk a little bit about definitions. Dr. Mena, in one of his presentations a little bit earlier sessions today, talked about health disparities, but I want to break down the difference between health disparities and health inequities. Health disparities are defined as a population where there's a significant disparity or a difference in the overall rate of a disease incidence, prevalence, morbidity, mortality, or survival rates in a population as compared to the health status of the general population. That's from Minority Health and Health Disparities Research and Education Act in the year 2000. When we talk about health inequities, it's a little bit different. When we talk about health inequities, we're talking about disparities in health or healthcare that is systematic and unavoidable and unjust. So that's a little bit of a difference when we talk about that. And that definition is given by the CDC themselves. Some of the foundations for these sexual and other health inequities that we see, this is the laundry list we talk about a lot in public health. So you see unemployment, uninsurance, unequal access, poverty, conditions and discrimination, oppression from racism, sexism, sexual and gender prejudice. There are a ton of other social and structural factors that we could include in that. That's just a smattering of the few ones that we see the most often. And then if you look at health equity, I love this diagram. We'll talk about it in a second, but I found a wonderful commentary from Dr. Paula Braveman in Public Health Reports back in 2014. And she said health equity and health disparities are intertwined. Health equity means social justice and health, i.e., no one is denied the possibility to be healthy for belonging to a group that has historically been economically and socially disadvantaged. Health disparities are the metric we use to measure progress towards achieving health equity. And so again, there's this kind of difference where I think if we break it down, health disparities are just talking about the numbers and just the statistical differences that we see in some of these outcomes, whereas health equity is the acknowledgement and the recognition that they are driven by kind of unjust and unfair social conditions and social structures. And I like to see this one here. There's another diagram that's similar to this when people are watching a baseball game. So when we talk about equality, you have tall people all the way to short people, someone who's kind of medium height, and you all give them a box to say, okay, go ahead and get your food so you can access food. That's what people would call equality. Everyone gets a box. When you talk about equity, that's where you actually address things according to the disproportionate levels of social disadvantage that people may have. So in this case, for the shorter person who can't reach the fruit, they get 3 boxes so they can stand, whereas the taller person who already has an advantage to pick the fruit, now we're talking about true health equity. So there's a little bit of a difference, not only between disparity and equity, but also equality and equity. So some of the reasons that you see in the literature, and again, this is just a smattering, it wasn't meant to be overly inclusive of all the profound literature that is out there. Some of the reasons for the racial inequities and STIs that we see. Income inequalities we see a lot of times. There was an MMWR that reviewed some of the data from previous and some of the history and noted that the funding decreased and there was a reduction in public health services and STI clinics from 2008 to 2012. And if you notice on the graphs that I showed a little bit earlier, where you see some of the upticks in the STIs, it does happen around that time, around the change of the decade or around 2013, you start to see things creep up. So there is a direct correlation that we can see. We may not be able to say it's always causal. There may be other factors involved, yes, but there may be a correlation between what we're seeing with obviously dropping the funding and reducing the public health services. And of course, in these times and days, we're going to see more Black and brown people be disproportionately affected by those cuts in fundings. Another reason could be segregation, clinic variability, and STI guideline adherence. There's been a number of studies that have talked about how private practices tend to not adhere to the guidelines as well as our public STI clinics. People talk about sexual networks and concurrency that may be driving this, racial concurrency between partners. And then finally, what we've talked about a lot already, and I'm sure will be talked about during the rest of the conference, is racial bias and racism, which not only can lead to structural and environmental obstacles, employment barriers, and similar barriers to care and testing as with HIV, COVID-19, et cetera. And then we have entering COVID-19 into the equation earlier this year. And so this was Dr. Harvey actually presented in the session right before this one from National Coalition of, I want to say STI directors. I know I'm changing the name, so I'm sorry about that, but I'm going to change everything STD to STI. Survey of STI program directors, disease intervention specialists, and clinics. They did 2 phases. This is just a smattering of some of the findings they found from the survey. 62% of them were not able to maintain their HIV and syphilis caseloads. 83% of the STI programs are deferring STI services or field visits. 66% of clinics report a decrease in sexual health screening and testing. 60% of clinics reported experiencing reduced capacity to treat STIs. And then 50% or 57% of the DIS, the disease intervention specialists, reported that they or the other DIS workers in their jurisdictions had been redeployed to COVID-19. None of this should be surprising. And what we see in this is kind of a public infrastructure that has to respond to a pandemic. And so you shunt resources from one traditional focus to another. And that's exactly what has been transpiring since this pandemic really hit. This is a quote from a southern state whose STI staff had been mostly redeployed to the COVID-19 emergency response. They said, STIs and DIS staff are working 7 days a week and are doing their very best to save lives like they always have. But this effort is not sustainable. Staff are burnt out, tired, overwhelmed, and scared. And again, you think about my title when I said naked and afraid, it also speaks to how we've been stripped down by this pandemic and how it is scary that someone says the word scared, not only for contracting COVID-19, but also how we're going to provide these services to the people that need them. And am I going to put myself or my family at risk? COVID-19 has really changed the game and kind of up things and really stripped us down to our bare essentials. And this is a graph that kind of shows this. These are the number of chlamydia tests among all people aged 15 to 60 years by week. And you can see the blue graph is from chlamydia tests in 2019. You can see there's a few dips here and there as you go along the weeks in 2019. But then you see even before March 13, where it was declared a public emergency, you can see that people were already fearful and stopped going. And the number of chlamydia tests were dropping down as well. And then it started to tick back up to be where we're at right now. But you can see COVID-19 has had a profound impact and will continue to have an impact on how we address care, how we address sexual health and STIs as we move forward. So what's the problem that you see here? So we have infrastructure that's already inequitable and set up to fail, now having to respond to a pandemic. You have inadequate and or reduced funding for access and services. No one probably saw from 2008 to 2012, when they reduced a lot of the funding to the clinics and to some of these public health services, that a pandemic would be around the corner in 6 to 7 years. So now you're dealing with less money, less staffing, less resources to deal with a pandemic and try to treat STIs. And then you have the priorities seem to be a lot of times in policing and shaming instead of support and affirmation. We still have people trying to publicly and privately shame people for STIs and sexual behavior instead of using affirming approaches. And then as a result of all these things, the distrust in our healthcare systems are at an all-time high. And so not only are people distrustful of medical systems to begin with, but now with COVID-19, on top of that, they're scared to go because they're afraid they're going to get COVID-19. So this is the conclusion of the story of what happened with the young student that went to be seen for him being in contact with someone with confirmed syphilis. So I spoke to a colleague at the state DOH and I connected him to her. And she got him a walk-in appointment at one of the local STI clinics the very next morning, which was a Friday, which was wonderful. And she called him directly. He said it was okay to give her his information. She got him lined up. So he texted me after that and explained the visit. And these are the exact words that he used. This is his exact test. I took a little bit out of the end because he kind of identified the provider that took care of him. So I took that out, but the rest of the words are his. So this is what he said. I just got the shot. I'm so thankful for you and Miss the person who helped from the DOH. Everyone there was so nice and informative, but the doctor pissed me off and made me feel so bad. He kept talking about the epidemic and how it's a behavior issue and basically preaching to me, trying to make me feel guilty and pressure to make a decision to do something about, quote unquote, what I'm doing wrong. And this was him acting like he was speaking to the physician. I've thought about that all by now. Just give me what I need so I can leave. So after this student has been at 3 different places, the student health clinic at the summer school he was attending, to an urgent care clinic where he got kind of the second line treatment as opposed to the first recommended treatment. And when he finally gets the first recommended treatment, he gets a little dose of shaming and judgment on top of that while he's getting the treatment that he deserves. I was amazed at this young man's resilience, that he would actually put up with this. And I was texting him and calling him literally for those entire 2 days until we got him taken care of. And so I was glad it worked out and he was able to get that treatment that he needed. So what was wrong with this student, or what went wrong with this student? So first of all, we had mixed messages with the guidelines. You have a PA that's telling him that you don't have to get syphilis tests. You can't get syphilis tests unless you get all the tests. And there's no need in getting the test now because it's not going to come back for 3 months. And then you have a nurse practitioner who's basically telling him that, oh, we're going to give you twice-a-day pills with more side effects for 2 weeks, and not even present to him the option for the first-line therapy. So you have problems with that too. You have subjective deviation from the standards of care, which is what essentially these people were doing. You have a lack of resources in healthcare settings. In urgent care settings, I know there have been problems with penicillin and the cost, and contracting for the cost in the past. But why would you not have, if you're doing STI screening, why would you not have penicillin available? I am penicillin available. And also particularly if you're getting a lot of strep throat, that's one of the recommended treatments as well. And then from the physician, they got judgment and shaming when they finally did get the shot. And finally, it's uncertain the motivations and bias of all these providers. But what I can tell you, if you think about this story, is that he sampled all the different types of clinicians he could have. He sampled a physician assistant, a nurse practitioner, and a physician. And he got different variations along the way and different barriers and obstacles. And I can't say exactly if he was a white cis heterosexual girl of the same age that he would actually have been treated differently or not. I would suspect that he probably wouldn't have been treated the same, but I can't pinpoint what's in the hearts and minds of those people that were giving him a second-rate treatment, that were turfing him away, or that were deciding to judge and shame him as they were giving him the treatment that he deserved. And just a reminder about the treatment here. When we talk about management of sex partners, and this is from the CDC guidelines, persons who have had sexual contact with a person who receives a diagnosis of primary, secondary, or early latent syphilis within 90 days preceding the diagnosis should be treated presumptively for early syphilis, even if the serologic tests are negative. And the recommended regimen for adults, benzathine penicillin G, 2.4 million units IM in a single dose. We all know this. These have been the recommendations since 2015, even long before that. So it's unclear what the confusion was with this or why he was shunted. I've seen some of the studies from the late 2000s that say that doxycycline twice a day for 14 days is just as effective as penicillin, and it probably is. But when you don't even present the first option as an option to this patient, something is going wrong, and that's where I think the bias comes into play. A word about expedited partner therapy, which is the clinical practice of treating the sex partners of patients diagnosed with chlamydia or gonorrhea by providing prescriptions or medications to the patient to take to his or her partner without the healthcare provider first examining the partner. That's a definition from the CDC itself. This was not a case of expedited partner therapy because this person got in to see a provider in person. But of note, in May, there was a letter from the CDC that said, the CDC does not recommend the use of expedited partner services for the management of sex partners of individuals diagnosed with syphilis. The reason behind this letter was because a lot of the literature is inconclusive with syphilis, but it is more conclusive with chlamydia and gonorrhea. But again, with this point, and I know one of the sessions previously, they said in New York City, they're actually expanding EPT to include syphilis contacts. So I think while we have on the national federal level, the CDC being a little bit more conservative with it, independent states, and particularly New York tends to be more progressive on these things, is actually doing this, meeting the needs of the epidemic or the pandemic. So why do I put these pictures here? I'm putting a picture of Defund the Police from a rally, and then some healthcare workers with Black Lives Matter taking a knee probably for the 7 minutes and 46 seconds or 8 minutes and 46 seconds. I think people are still debating that. The end result was still the same when George Floyd had the policeman's officer on his neck. So I put the title of this Changing Culture, Not Just a Few Bad Apples. It is really wonderful to see the medical community stand up in solidarity against police brutality geared towards Black men and women and non-gender conforming folks who don't get as much as the media time as they should. And so we make these cries for defunding the police and so on and so forth. And if you hear with law enforcement, you hear them say, oh, it's just a few bad apples and it's not really a culture. It actually is a culture. And there are several bad apples. But at the same time, when we're looking at ourselves as medical professionals, it's great that we want to take a knee to protest law enforcement practices. But we should be actually looking in our own homes, our clinics, our institutions, our hospitals, our medical systems for the same type of racism that happens with your colleagues. And we keep calling for people in the police department. Well, why did those guys stand around when he had his knee on George Floyd's neck? Well, why did you stand around where someone made a racially insensitive comment or an anti-immigrant comment or an anti-trans comment and you didn't say anything? If we are going to critique law enforcement for not stepping up and holding their counterparts accountable, we have to actually start with ourselves first. There are a lot of similarities between the two cultures. And there's what we call the blue code of silence, where law enforcement officers protect each other and they will lie for each other and cover each other up, even when they know something's wrong. We do not need a white coat of silence similar in the medical profession. So when we talk about defunding the police, people are talking about reallocating funding. I say, if we do defund, we need to actually defund our approaches to sexual health and STIs as well. That involves getting evaluations and needs assessment, redirecting and reallocating funds, reframing health over disease, and realizing that this is not a one-size-fits-all equation. I think the CDC will do an amazing job at putting out federal guidelines, but it will be up to the individual discretion of some of these states to move the needle a little bit farther. And so you guys have a lot of power with that within your individual institutions. As protectors and healers and conveyors of health in some of these clinics and medical spaces, we must hold ourselves accountable the same way we demand that law enforcement hold themselves accountable. Protect and serve is what they say with the police officers. And that equates to me, it's comparable to do no harm, which as a physician is part of the Hippocratic Oath that we recite when we graduate. Anti-racism and cultural humility infrastructure changes are needed for all staff, not just training, but change the whole complexion of how we operate in these things. I used this slide. This was an old public health program or public health, I'm blanking on the name, a public health initiative that basically started talking about HIV prevention starts with me. And it was targeted towards individuals. So whether you were HIV negative or you tested positive, HIV starts with me as a member of the community. I can actually be on PrEP or use condoms or watch my behavior, or if I'm living with HIV, same thing, plus I can take my medication. It starts with me. What I say in this case is that it still starts with you. And while we talk about systemic oppression, we talk about institutions, the fact of the matter is that there are individual people that are at the heads of these institutions. And even if you're not at the head, even if you're somewhere down the line on the hierarchy, never underestimate your voice and how powerful one individual's motivation can be. It does start with you. So if you're seeing some of these things that I'm talking about, and you're listening to the story that I told you about this student, there are ways you can step in if you witness that, and never underestimate what you can do. Whether you're a case manager, a social worker, a DIS officer, PA, NP, physician, you can do something when you see something wrong. And never underestimate the power of an individual, even within systems that have problems. That's how it starts. Shout out to my colleague and Wonder Twin, Dr. Kim Manning, who is in the Division of General Medicine. She, for her 50th birthday, which was about a week ago, decided to raise some money for Grady Hospital. She wanted to raise $50,000 for her 50th birthday for Grady Hospital. She put it on social media and ended up raising over $200,000, and she was actually scared. She had imposter syndrome, worrying, who am I to actually ask for $50,000 and how am I going to get this? And then she got 4 times that amount, and she may even get more. So again, never underestimate your power to work within institutions to institute change. A quick word about stigma and a shameless self-plug. I got the opportunity to work with the amazing pediatrician in adolescent medicine, Dr. Errol Fields, and also the infectious disease and public health goddess, Dr. Sophia Hassan, on a review of HIV prevention literature among young Black men who have sex with men. It just came out. It was just published online a little bit earlier this week, and it's in current HIV/AIDS reports. What we found when we talked about HIV prevention is that we do talk a lot about HIV stigma that impacts HIV prevention. I will say about stigma, it actually impacts sexuality long before you get to HIV. And so if we're really serious about addressing the STI epidemic, we have to address our stigma when it comes to sexual behavior, not just STIs, or whether someone gets herpes or gonorrhea or chlamydia or syphilis, but around the behaviors themselves. And when we're talking about a disease and pathological based approach that we typically use in public health and a lot of our STD clinics, it's not about health and wellness. And we need to change the language and change the culture of stigma around that. And in order to do that, we have to tailor our approaches to sexual health. Obviously, plenary speakers, myself included, I don't have all the answers to all these things. And me living in Atlanta, it may be different from what's happening in Denver, Colorado, or New York City, or Boston, Massachusetts. Every county, state, city, and locality has different contexts with regards to their communities, funding, resources, and personnel. So our institutional policies, procedures, and personnel training may need to be stripped down, naked and afraid. We may need to strip everything down and go back down to the basics and figure out what we need to do. And some core concepts need to be readdressed and reapplied. One of these core concepts is what sexual health actually means. And I was glad to see Julia Marcus mentioning this a little bit earlier. According to the World Health Organization, this is the exact definition: a state of physical, mental, and social well-being in relation to sexuality. It requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. I highlighted discrimination because I do sense that what this young man went through as he was trying to get evaluated and treated for his contact to a known syphilis case had some level of discrimination, why he was getting the runaround and why he was getting second-line treatment as opposed to the first-line recommendation. Always look to Canada for some of the most progressive stuff. This is an ad from Action Canada for sexual health and rights. Sex ed keeps us healthy. And you can see this kind of amorphous figure eating an apple. There's a lot of connotations there with the kinky boots that they have on. You look over here with suggesting the fluidity of gender expression. You have bacteria and microbes that you could have here, condoms, pills, possibly for PrEP or HIV treatment. You have sperm going to an ovum, and you have a heart with two hands holding each other, suggesting that intimacy also is part of sexual education and sexual health. So I think when we talk about changing institutions and cultures, it may be high time that we actually use some of this motivation and use some of this time that we have now to restructure how we administer these services in either publicly funded clinics or in privately funded clinics where you work. Addressing sexual health and STI prevention is absolutely crucial. Why? Because it reduces the community burden of disease. It improves public health. Obviously, it enhances HIV prevention efforts. We know a lot of the literature that talks about the increased rate of HIV transmission if someone is co-infected or has herpes or syphilis as well. It improves individual and community level mental health. That fourth point we don't talk about enough. The stigma and the shame and the confusion and the anxiety and the depression that goes with an STI diagnosis, any of them, the cured ones, the ones that we can cure, like gonorrhea, chlamydia, and to a certain extent syphilis, people tend to get over. But you think about things like herpes and HPV, you think about those kind of long-acting STIs, the viral STIs that stay with you for a lifetime, the impact on mental health is substantial, and we need to address that as well. And then finally, if you need an argument of why sexual health and STD prevention is crucial, for the business people out there that always want to save money upfront by cutting funding, think about the financial cost. From STI services, this was estimated by the CDC in 2013, $16 billion in the United States in direct medical costs alone from sexually transmitted infections. So if we can do something front-loading and figuring out some way to get things better, or maybe reallocating, defunding, whatever it takes to get that up front, it may not happen immediately, but years down the road, we may see those costs start to go down. So for those of you that need a financial incentive to do that, as if the rest of it isn't enough for you, that's the financial incentive. So moving forward, what can we do? We're in the time of COVID-19. We don't know how long this is going to pan out or where it's going to go. We're learning something new every day. It's a perfect time for us to change how we do things. While we're reestablishing things with telemedicine, while we're reestablishing how we interact with patients and each other and how we deliver medical services, it's a perfect time to reevaluate our guidelines, what we do, our policies and procedures, and then enforce them regularly. We need to endorse science, not judgment. We need to sit a little bit with our vulnerability. If we're feeling a certain way or if we're uncomfortable with it, it's okay to feel uncomfortable and vulnerable. Just don't take it out on the patient. But remember, we all get scared and afraid at some point. And then we actually have to hold ourselves accountable to one another. If we are going to sit there and protest police brutality to Black people, and we say that all these cops and all these people in law enforcement have to hold themselves accountable, then we have to hold ourselves accountable in the medical spaces where racism happens just as often, if not more, than in law enforcement settings. So then looking at the little parallels here, and I don't know if you can hear the rain, it just started raining down here. I'm sorry if there's any noise from that. So when it comes to Naked and Afraid, the TV show, and moving forward with sexual health and STI prevention, there are a few parallels that I can draw here. First is your tools for survival. On the TV show, when you're naked and afraid, you get to choose between a machete, a fire starter, a cup, things that you'll get through. If you're working in the sexual health field, you get to choose your DIS workers, case managers, the staff and the providers you want to have, the supplies, the navigators you want to use, and the community resources you can have. And then you want to identify your resources in the area. When two people are thrown in inhospitable weather and climates, they have to look for things like rivers or creeks for food, trees and other food sources, whether it be bugs or whether it be wildlife, snakes, fish. They have to figure out what to do. So with us, we got to figure out how to move forward with our sexual health initiatives, with the funding, with community capital, with passionate staff. How we kind of arm ourselves to move forward is going to say whether we survive this or not. And then we have to prioritize our needs. So for two people who are naked and in the wilderness together, they need to figure out how to get water, how to construct shelter, how to start fire, to keep the water clean and cook food, and also what they're going to do with foot covering, because a lot of the environment is really harsh on the skin. Similarly, when we're moving forward in sexual health, we need to talk about education and empowerment, health and wellness, identifying and treating people who are living with STIs or who get exposed to STIs, and then finally contact tracing so we can get in touch with their partners. And we need to prioritize these needs over some of the other things that may be able to wait a little bit longer. And then working together is one of the things that two people out in the wilderness who don't know each other and are just butt naked trying to survive an inhospitable climate will have to do. They have to work together, put together shelter, get food together, support each other when they get sick. And similarly, when we're working in the sexual health field, we do need to negotiate things together. We do need to bond together to work against some of the politics that are happening right now, some of the other forces, social and structural and community level, that are trying to work against us so we can't do our job. So we have to learn how to work together to get through this whole thing. And then finally, when it comes to follow through, with Naked and Afraid, the TV show, either you stay on through the whole 21 days and you survive and you get to your pickup point and somebody picks you up in a Jeep or in a boat, or you tap out. If you feel sick or if you feel you just can't make it, you just tap out. And similarly, if you're going to be involved in the sexual health field, you really have to know and have a passion for this. And you can't be someone who lets their implicit bias and their judgment take over, because that's going to be no good for the patients. So you can either train yourself, humble yourself, make yourself a little bit more vulnerable, and figure out what you're going to do to stay in the field. Or if you don't feel you can cut it, just go ahead and tap out. So my wish list, this slide just talks about what I would kind of want as we're moving forward with sexual health initiatives. So improve telehealth infrastructure, on-call and mobile services, and also at-home testing, if we can do that. Better paid and appreciated case managers and DIS workers are going to be needed. Affordable benzathine, penicillin G would be nice, azithromycin and doxycycline. All those things, if we can work on making those things more affordable without the shortages, that will help our patients. Cultural humility practices, i.e., don't be racist, don't be sexist, don't be transphobic or homophobic. Just accept people for who they are and leave your judgment at the door when you come into work. Less bureaucratic red tape, and also community-led creative strategies. We've already been doing some of that with COVID-19, but we can push a little farther. The final three things I really want to focus on. So declaring sexual health as a right is something we need to formally do. We also need to reframe sexual health beyond infections and diseases. And we've gone from calling them STDs to now we call them STIs. But I think we can go even farther to talk about sexual health just in general, and then underneath that umbrella would be infections, so on and so forth, and other aspects of sexual health. I think we can reframe that now and move forward in a much more affirming and assets-based manner. And along those lines, I would recommend to the CDC with this conference, either renaming it to the STI Prevention Conference to keep up with the common nomenclature now, or call it the Sexual Health and Wellness Conference, the CDC Sexual Health and Wellness Conference. And then you can have different tracks of presentations that are about STIs and treating STIs. You can do other things with just sexual health, whether it be psychological, mental, erectile dysfunction, desire, premature ejaculation. You can do all those different things. So I think it's a time that we're finding we can evolve and kind of expand what we do. And particularly with this conference, I think it would be great to either change the name to the STI Prevention Conference or the Sexual Health and Wellness Conference. That's just my humble opinion. So here's a picture of what folks look like after they go through the TV show Naked and Afraid. They lose a lot of weight. They're dirty. They probably don't smell too good. Their breath is probably stinking at this point. They look kind of happy. They're dirty as hell. But it's just what it is. But they get through this stuff as they've made themselves vulnerable. They've worked together and they fought through it. Similarly, I think all of us are going to look like this when we come through how we're going to handle sexual health and STI prevention during this COVID-19 pandemic and then moving forward into 2021. So I commend you all for the work that you've been doing. You all have been making yourselves naked and afraid. You have been stripping down things. You have been making yourself vulnerable. So keep on that pathway, keep on that journey, because we will make it through together. We just have to incorporate some changes, realize some things are out of our control, and then we just get to move forward together in providing the best services we can to our communities and our patients. Final acknowledgements. I'd like to acknowledge Dr. Matthew Hogben, who invited me to do this plenary, Dr. Sevgi Aral, who talked me off the ledge when I felt like I didn't want to do it or didn't have the emotional capacity to do it. And then finally, Dr. Jamie Licklider was really instrumental in helping getting me some slides and also kind of encouraging me to move things forward. Finally, I'd like to dedicate this opening plenary. We've had a lot of loss in 2020. And as a Black man, I want to recognize some amazing Black men that we have lost in this year. And going clockwise on this side, I'll start with Congressman John Lewis, who unfortunately passed, civil rights icon who did amazing things for our country, both in the 60s and beyond. Coach John Thompson, who was the former coach of the Georgetown Hoyas, who was the first Black coach to win the NCAA Division I basketball tournament, men's basketball tournament, as he coached the Georgetown Hoyas. Amazing inspiration. I was in high school when it happened, and he was very much an activist as well. Chadwick Boseman, who obviously played characters from Jackie Robinson to Thurgood Marshall to James Brown, and probably most famously the fictional character Black Panther. We lost him earlier. And then finally at the bottom left, that's a picture of my father from the 1970s. And I may be biased. My father passed away, like I said, in early January of this year at the age of 87. But in my bias, when I look at all these four men, the one who has the most fashion sense and who's really doing some 70s styling is my father in that back. I know you guys are loving his hat and coat, but that was the kind of man my father was. And I wouldn't be here without his inspiration. So I'm very thankful for him and for all these wonderful men who grace this dedication page, that I'm thankful and sorrowful, but I'm just celebrating and lifting up their spirits at the end of this opening plenary. That is it for me. I want to thank you guys for paying attention. I apologize for the glitch. My power went out and I had to re-record some of these slides at the end, but I hope you all enjoyed the plenary. This is my contact information. My email is below. I'm on Instagram and Twitter, so please feel free to reach out to me, but keep doing the amazing work you're doing. We'll get through this year. I know it's been hard for everybody, and enjoy the conference. Take care.
Thank Dr. Milbranch's presentation. We were having some technical difficulties, but I think we were all inspired and enlightened by his presentation, and really, it really emphasizes how we're at a time to appreciate the past of STD prevention and embrace really the evolutionary time we're in. And I can't say enough how inspired I was by his presentation, and I'm sure others in the audience were as well. And so now, as we close, we would like to take this opportunity to thank our sponsors, NCSD, Hologic, ACSTDA, and Abbott Pharmaceuticals. And I'd like to highlight a couple of upcoming events as well during the conference. The ASTDA Awards Luncheon will be tomorrow, September 15th at 12 p.m. noon Eastern Time. And Hologic will sponsor a special session on Friday, September 18th at 11 a.m. Eastern Time. And for those of you who pre-registered for the networking icebreaker, it will start at 5:30 p.m. Eastern Time following this event. And otherwise, we'll see you tomorrow at 11 a.m. for our first plenary session. We planned a great conference this year, and we hope you enjoy all of the learning, sharing, and networking opportunities provided. Thank you to everyone for joining us, and have a great evening.